Hi, I'm Nancy Brown, CEO of the American Heart Association, and I'm here today with Dr. Marielle Jessup, President of the American Heart Association, and Dr. Sid Smith, an immediate past President of the American Heart Association and Chairperson of the Guidelines that we're here to talk about today. Sid, I'd like to start with you. Recently, the American Heart Association and the American College of Cardiology published 4 new prevention guidelines. Before we talk about those in specific, I wonder if you could take a step back and talk about the importance of guidelines to patient care.
Well, Nancy, as you know, guidelines are really a way that we bring evidence together and put it out there so that clinicians can use it when they take care of patients. And it's actually been 10 to 15 years since we have really come out with new guidelines in prevention.
And the new guidelines that were just recently published by the American Heart Association, American College of Cardiology, could you tell us a little about those guidelines, what they are, and why they're important to patients?
Well, these guidelines are very important to patients because they bring together the latest evidence on prevention. They bring together advice on diet, on exercise, on obesity, on how to assess your risk of having a cardiac event, and what medications might be helpful in addition to changing your lifestyle.
Great. And Marielle, these, of course, are signature guidelines for the American Heart Association. Can you help us understand why they're important to the AHA and our mission and our 2020 strategic impact goal?
Sure. Well, remember that not only do we want to reduce mortality from cardiovascular disease and stroke, but we want to help people lead healthier lives. And these prevention guidelines are really the same thing. It's leading healthier lives because they'll prevent heart disease. So the same recommendations we make for Life Simple 7, leading healthy lives, turn out to be the recommendations to prevent cardiovascular disease and stroke.
And both of you are practicing cardiologists. You see patients every single day. How does a guideline affect the way you care for a patient? So if you are a physician in the community and you receive word of the new guidelines, what do you do with it, and how does it help direct how you talk with patients and assess their risk? Marielle?
I think lots of people have questions. They come in and say, my cholesterol's 210. What should I do? Do I need to be on a statin? And the clinicians don't have that information. They have to turn to a source. The ACC-AHA guidelines have turned out to be that source in this country. So we turn to the guidelines and they give us recommendations about how to treat that patient in your office with the question about their cholesterol and whether they should be on drugs.
You know, for years and years, the ACC and AHA have published and created practice guidelines. We have a wonderful brand recognition in the community of cardiologists and primary care providers for these guidelines. Sid, I'd like to just ask you to go a bit deeper about why these have such credibility, the process that we use to create guidelines, the capturing of evidence, so that our viewers can really understand the level of depth that we go to when we think about creating these new guidelines.
Sure. And as a physician, you know, every year the American Heart Association, American College of Cardiology will present randomized trials at the meetings, and the evidence keeps accumulating. Now, I, as a cardiologist, need to know how I fit that evidence into my practice. Also, as someone who's teaching at a medical school, we need to understand how we structure courses for our fellows and residents. So this process that the American Heart Association and American College of Cardiology have put together over the last quarter of a century is one of the best I know in guideline work. We basically look at the evidence through a process called systematic review and grade it. How strong is it? And then put it into meaningful recommendations to physicians that they can use in taking care of patients. When should a patient be on statins? What is the best diet? How much exercise should you have in a day? What do we really know about weight loss? It brings the science into how we take care of patients, into a very important dialogue with the patient. And the patient is very important in terms of how we take these guidelines and put them into practice.
Is it fair to say that millions of people's lives have been affected positively over the years because of the work of the AHA in creating these practice guidelines?
Well, I think it'd be very fair to say that the American Heart Association, American College of Cardiology guidelines have affected millions of lives. They have reduced heart attacks and actually kept people from dying and having strokes. So these are critical, and it's very important as we have new science to bring that into practice. And that's where these guidelines make a difference.
And that's why these 4 new prevention guidelines are so important. Prevention is in the center of what we do with the AHA. So Sid, I'd like to have you talk for a minute about the importance of publishing these 4 guidelines together, the bundling of the guidelines around looking at the whole person in prevention.
Well, Nancy, it's a very important point that these are coming out together. We're not releasing something on what do you do about risk without giving the doctor and the patient some information. If you are at risk, here's what you should do. So they're coming out together, and I think there's one very important word that goes with education, that's implementation. The American Heart Association, through the Get With The Guidelines programs, is known worldwide, and that is getting the message out, not just releasing a book, here's what you should do, or a publication, but here's how you can do it, and we're here to help you with that. So from my standpoint, a very important point when I agreed to chair this whole process was that there would be a commitment to implementation. And I think that's an area where the American Heart Association, American College of Cardiology can really make a difference, not only saying what should be done, but helping understand how it can best be done, particularly in this time when healthcare is changing so rapidly. We've got to have new systems of communicating with patients, working in a hospital, and seeing that the treatment strategies really occur.
So when we look at the 4 new guidelines, what's different about these guidelines, Sid, than what we had seen before?
Strong base on evidence, much more evidence is available. It's been 10 to 15 years, and so understandably a lot of trials have come out with more information, with the use of statins, on treatment of the way we assess risk. For instance, our previous assessment of risk used a Framingham study, which did not include a lot of African Americans. We have expanded the risk assessment to include African Americans and also to include stroke as an outcome, not just heart attack, if you're going to die from a heart attack, but what is your risk of having a stroke? So we've broadened the guideline, the risk assessment, to make it more applicable to our population, more representative. They're keeping pace of our population as we grow into this beautiful racial, ethnic mosaic, that we now have guidelines that meet the needs of the population and importantly bring evidence to what we're doing.
That's great. And Marielle, I wonder if you could comment on this. There's been a lot of talk in the press about the risk calculator and the cholesterol guidelines in particular. And so, to recap, the cholesterol guidelines are one of the 4 guidelines that we recently published, and the risk calculator is a tool that helps healthcare providers understand how to assess risk of patients, as Sid was just saying. Could you tell us a little bit about the controversy? What is the controversy? Why is this controversial?
Well, I think we need to know what has been before our guidelines came. Clinicians have been taught through previous guidelines to aim for a target LDL level, depending on the risk that the patient or the event the patient had.
And if I can stop you right there, let's make sure that our viewers remember the various kinds of cholesterol, the total cholesterol, the HDL and the LDL, and why they're important.
So remember, LDL should be low, so L and LDL. So the LDL, because it's the bad cholesterol, should be low. And we were taught, for example, somebody that had had a heart attack, a myocardial infarction, their LDL cholesterol should be below 70. And a whole series of events came after that target of LDL. So people's electronic medical records were watched and assessed for how many patients had an LDL below 70. Performance measures and quality measures are all built around this. The new guidelines have said, you know, we don't think LDL is the right target. We want to target patients at risk and treat patients who are at the highest risk. So this is a huge sea change for clinicians who have been accustomed to looking at a blood test rather than stepping back and looking at individual patients and assessing their risk. Now, some patients in our new guidelines right away have very high risk. They're patients that have had a heart attack or had a stroke or have other evidence of atherosclerosis. There are other patients, and the guidelines suggest that they should be on intensive statin therapy, which translates into a certain dose of therapy. There's other subsets of patients who straight away get placed on a statin. But the risk calculator falls into patients that don't immediately demand a certain dose of statin or an intensive regimen, and you will calculate the risk. You put in certain factors about individual patients that calculates a 10-year risk of developing death, heart attack, or a stroke. And this is where a lot of the controversy has been. The risk calculator is based on real patients, patients that were followed for a 10-year period. So that means that these patients had to be followed starting at least 10 years ago, and ideally nothing should have changed with those patients. So they were followed starting in 1990. They just carried out their lives, and in 2000 we could say, here's what happened to them, and base our calculated risk on that. Well, people don't stay the same. They've gotten healthier, they've stopped smoking, they've taken statins. And so the risk calculator, the arguments around the risk calculator, is not that it's not a great idea to try and calculate risk. It's what populations was this risk calculator based on? Were the right kinds of groups, which we call cohorts, included in this analysis? And that's where all the discussion is. Not so much that it's not a good idea to calculate risk, but what are the right populations to develop that risk?
So,
can I jump in on that for a minute and
yes.
say, one of the things about these guidelines is the evidence review. We were looking at evidence. I was on the committee, and there was a clear, consistent signal that if you look at the randomized trials with the statin use, that patients at a much lower level of risk than would have been recommended in the previous guidelines were getting benefit. We are seeing patients at 10% risk, 7.5, all the way down to 5% risk. Low risk are benefiting from statin therapy. So if you look at the previous guidelines, maybe 15 million patients would have been recommended to be on therapy. We know that 33% of our population, that's roughly 33 million out of 100 million, die every year from heart attack or stroke. And we're seeing now, using the new evidence, that roughly 31 million patients should be treated. That's pretty close to a third of the population that we're saying are dying from heart attack and stroke. So if you look at the evidence from the trials, it really tells us that we can do a better job if we begin to treat patients at lower risk than was previously recommended.
At the end of the day, what does the American Heart Association think, and why do we think these changes are so important?
Yeah, well, at the end of the day, the American Heart Association thinks the patient is the most important person in this whole discussion. And so nothing gets done without talking to the patient. Calculating a risk, doing a test, all very helpful. You need to know, I need to know, you need to know, we need to know our risk. But that patient-physician discussion is central. That's the most important thing coming out of these guidelines. And if a prescription gets written, if lifestyle is changed, it's a part of the patient and physician talking about what the patient feels, what may be in the best interest of the patient. So there is no calculator that replaces the discussion between the physician and the patient.
As a matter of fact, really, the calculator is simply a tool to help facilitate that discussion.
Exactly.
So Marielle, back to you. One of the other criticisms that we've heard is about the pharmaceutical industry, and some allegations, perhaps, that members of our writing groups were influenced in their opinions in looking at the evidence by relationships with the pharmaceutical industry. It would be really helpful for you to describe a couple of things, I think. First of all, what are our policies around how we constitute writing groups, and how do we look at relationships with industry? And then in these guidelines in particular, is that allegation true or not true?
So our joint task force run by the American Heart Association, the American College of Cardiology, has for many years a rigorous method to separate out the people who are writing the guidelines from any potential conflict of interest. So before a writer of these guidelines can even come in and join the committee, they declare their conflict of interest. They promise to set aside those conflicts. They don't develop any more relationships with industry. And even if they've had a relationship prior to being on the committee, if there's a subject that comes up that they have a potential past conflict, they declare that they stay out of a discussion and out of voting. So that has been the process for many years, that when there is any potential conflict, the writer that's on this committee will refrain from voting on a recommendation. So that's the general policy, and those were the policies put in place for our prevention guidelines.
And can I just drill a little bit more? And so we have this overarching view that the chair and the co-chair of our guidelines have to be free of all relationships with industry, and then the writing group itself, no more than 50%
right,
can have any relationships with industry, and all of that's disclosed on a table
right,
that we publish with the guidelines.
Right, exactly. And I think for the cholesterol guidelines in particular, the chair has been very clear that he refrained and disassociated himself from all industry. He did not vote on anything that was critical. And in fact, what I find particularly curious about these allegations that these guidelines were governed by people that had conflict of interest is that these guidelines don't name drugs. They name a variety of drugs, most of which are generic. And so even if you wanted to assume that somebody had a conflict, it's not obvious where that they could benefit from this conflict. So no, I don't think these allegations are true, and I think they're not germane to the real discussion that we're really trying to make a change in how we treat patients.
Sid, you were so actively embedded not only in leading the entire guideline process, but in particular writing groups. Give us your perspective on this issue of relationships with the pharmaceutical industry and the allegations of that these guidelines were influenced.
Well, I don't know about the allegations, but what I can tell you is that on every vote, anyone that might have had a relationship that could have influenced the vote did not, they abstained from voting. So I don't think that there's any substance at all that some type of relationship with the drug industry influenced these guidelines. These guidelines are based on evidence, very strong evidence. In fact, there's less opinion in these guidelines than might normally be accounted. And it's really when you get to opinion where you worry about how a relationship, you can't argue with the evidence. The evidence is the evidence. It's there. And when it comes to the medications recommended, the cost of these statins that are being recommended generic over the counter, $4 a month.
Right.
These are not designer drugs. These are drugs that have been out for years that are now available in generic form. So I think you're dealing with strong base of evidence and inexpensive medications. The question is how best to use them.
And you know, at the end of the day, what we care about at the AHA is that patients are having this discussion with their healthcare provider to assess their risk and making decisions about changes in lifestyle and medications that can help them live longer, healthier lives. So the real important question is, how do we think these guidelines will be adopted in practice?
What I hear is that doctors and clinicians are saying, this is a good idea. I like treating the patient rather than an LDL target. Frankly, this discussion around the risk calculator is not something that is bothering the regular clinician on the street, because they've always realized that this risk calculator is a calculator and doesn't really pay attention to the patient sitting right there in the office. And so I think they intrinsically understand there's a conversation that has to have happen. So what we're doing is videos like this, letters explaining things, further articles, and we will update the guidelines as we do always. As new evidence comes along, we'll make the guidelines even more up to date, more relevant, find out where people are confused, address the confusion. And this is a process that we have been doing for, as Sid said, the last 25 years.
And of course, the tools and resources that the HA will provide to educate the patient and consumer as well will be important. Sid, what's your thought on that?
Well, one of the new tools in these guidelines are a group of patient vignettes, which goes through a 68-year-old African-American male with high blood pressure, or a smoker, or a 52-year-old Hispanic woman, different types of patients to help the physicians what they might do. Now, in addition to what the patients might want to do, have, and the physicians need to do to help them, the other thing that's important about these guidelines is when we move away from a target LDL, you get away from people pulling new medications off the shelf that may not have proven benefit. We're going with medications that we know work in a way that's very simple, and I think that's going to simplify physicians' lives as well as patients. I think the change will be easy once we get the new guidelines out and we get new systems out to help patients understand what's happening and physicians understand when to give a certain medication.
So you're confident that in the long run, healthcare providers will embrace the new guidelines?
Absolutely, and I think it's going to be simpler. Chasing an LDL, having patients come back with lab tests, using medications other than statins, which may not have proven benefit, will all be gone. We know the dose. If we base it on risk, we get the patient treated. I think we'll have a simpler system. Change is always a little unsettling, but I think this change will make things better.
I think that the best part of all of these guidelines coming out is it emphasizes what too often gets left out, which is lifestyle. Focus on exercise, focus on diet, focus on healthy eating. I hope that comes back in the conversation as the conversation around the calculator and around the changes. We realize that too often we've forgotten about lifestyle and focusing on that.
Which again goes back to the strategy of why we released the 4 guidelines at the same time, because we could look at risk, overall lifestyle, obesity, diet, all at the same time.
Exactly.
So Marielle, if there was one message you wanted to leave our viewers with about the importance of these guidelines, what would that be?
I think Sid said it. 1 in 3 Americans are destined to have a heart attack or a stroke, and they will die from these diseases. We need to prevent them, and it is preventable and it's treatable, and these guidelines are one more step based on good evidence written by people who wanted the best for their patients. So there's something, these guidelines can be trusted, and they are going to work.
Thank you. Sid, how about you? If there was one message you wanted to leave our viewers with about these guidelines, what would it be?
Again, I think you can trust them and they're going to work, and you need to take the first step by modifying your lifestyle. Changing our lifestyle can make a huge difference. And for those number of patients that are maybe a third of the population or less that might benefit for other therapies, we can tell you what works.
Thank you so much to both of you for your time today and for really your passion and leadership of the American Heart Association and the guideline process. We're indebted to you for many things and certainly for this as well. And thanks to all of you for viewing today.